the today's meeting. And we had first live donor kidney transplant in Vidarbha in 1990, and it was done by Dr. Acharya sir. And 22 years later, we had first successful cadaver kidney transplant at Vidarbha in 2013 April. And since then, the live kidney transplant program and cadaver kidney transplant program both are strengthening the roots, and we now have 15 plus kidney transplant centers in Vidarbha itself. So the transplant program is actually in great progress in Vidarbha. And as in the context of kidney transplantation, basically we have three important tests, that is HLA typing, HLA antibody determination, and HLA antibody cross-match. And there has been significant advances in all of these three tests. And now we are able to better stratify the immunological risk of patients. And there is an opportunity to individualize the immunosuppression. And the topic for today's meeting is the current understanding about histocompatibility and immunological evaluation in kidney transplant. And we have Dr. Jasmeet Kaur from Delhi with us to deliver the talk. We are pleased to have you, madam. Welcome to Nagpur. And on the chair, we have Dr. S.J. Acharya, the first transplant nephrologist of the region, and Dr. Shailendra Mundra, who helped us to establish cadaver transplant program in Nagpur. He worked for odd hours and gave us CDC cross-match, lymphocyte cross-match, and we were able to do so well as far as the cadaver transplant program is with us now. So I once again welcome you all for today's meeting, and then I hand over to the chair for the meeting.
Thank you, Suryashree. And it's my pleasure to welcome Dr. Jasmeet Kaur, the head of the Department of Histocompatibility and Transplant Immunology from Lal Path Labs. Dear friends, she has worked in Army for about 25 years, and after that she switched over to the private practice in Delhi and joined Lal Path Lab in 2014. And since then she is with Lal Path Lab, and she is doing an immense service to the transplant community, not only in India, but also abroad. We are very pleased to have you amongst us, madam. And now I hand over the place to you. Please go ahead with your talk, madam.
Thank you. Thank you so much. I can. So I hope this is visible to all. And I thank the Nagpur Transplant Society to have me, and I'm really happy to be speaking on monitoring strategies in transplantation, what we have been doing, and a little bit of the update on that front. So just a little bit for those who are not so much familiar, and the younger generation. So what is it that the HLA system really does? It helps us recognize the self from the non-self. And this is what really determines histocompatibility, which is actually the acceptance or rejection of a foreign tissue. But we also note that the HLA system is the most polymorphic system in the human genome, and therein lies the challenge of antibodies and histocompatibility. So to overcome that is what we really need to understand when we talk about transplant, irrespective of which solid organ, kidney, liver, heart, lung, or gut transplant. So what is it that HLA really does? So it's a lot of people seem to be wondering, what is it HLA is going to do? But HLA's main function is antigen presentation. But for the HLA, no HLA would mean no rejection. But unfortunately, we all do have the HLA system within us. And it is the self or the non-self which is determined. And it is the antibodies to the non-self, to the non-self antigens, which are the ones which can be harmful and are responsible for alloimmunization. Another point I want to highlight over here is that if there is an antibody to B7, as is shown in this particular diagram, there could also be antibodies to other antigens which are similar to B7, like B27, B60, 61, 13. These are all which would either be sharing an epitope or are cross-reactive groups which are present in the HLA system. And that is what the cross-reactive groups are there, and which is the basis of understanding the epitope matching as far as today's antibody detection is concerned. Having said that, a little bit about the expression of HLA. HLA class 1, where is it expressed? On all nucleated cells. It's inbuilt and it's expressed at high density on many cells. Whereas class 2 has limited expression. And this helps us when we talk about DSA to class 1 and class 2. Class 2 has limited expression. It's mainly on the antigen presenting cells, which are the monocytes, dendritic cells, or the renal mesenchymal cells. Or the class 2 HLA can be induced to be expressed on the endothelium and even the T cells sometimes. The sensitization to HLA antigens can happen on exposure to a large number of non-self MHC or other non-self antigens. And what are the primary sensitizing events? Blood transfusion, which is most common, pregnancy, that's why multiparity, previous transplantation, infections, and even vaccinations. So when we look at the kind of sensitization to HLA antigens and the classification, rather the subclassification of various IgG antibodies to various events, blood transfusion most common. Highest subclass, it will be IgG1. The second is pregnancy, which is again, and the most amount of sensitization occurs in a post-transplant patient. We know a lot of our patients do subsequently need to go in, or some do go in for a second transplant. They are the patients who are really highly sensitized and need extensive pre-transplantation workup. With the understanding of the antigens came the evolution of the DSA, and which was the first test we talked about when we talk about the DSA, and that's the lymphocyte cross-match. And Patel and Paul Terasaki did the landmark study in 1969 when they demonstrated the presence of recipient antibodies to antigens expressed on donor white cells. And I quote here from their article of 1969, where they said that their data was so compelling that the ethics of transplanting kidneys without prior knowledge of the results of lymphocyte cross-match tests can reasonably be expected to be questioned. And believe me, ever since, no transplanting surgeon or nephrologist has gone ahead for a transplant without a basic CDC cross-match. And this was the kind of study they performed many years ago. When we look at the cytotoxicity or the CDC cross-match, we have various classifications. There's the basic CDC, the standard NIH, and the no-wash cross-match. But the main issue is false negative cross-match results. I'm not saying the test is not good, but yes, a CDC cross-match positive is an absolute contraindication to transplant, but we've all in our practice encountered false negative CDC cross-matches when we do have donor-specific antibodies. Then came in the extended CDC, the extended incubation CDC cross-match test, the AMOS 3-wash cross-match test. So these were modifications of the basic cross-match test. And subsequently, there was the indirect cross-matches, which incorporated a second step to augment the CDC cross-match itself. And these were the HG augmented CDC, which increased the sensitivity of the basic CDC, and subsequently the flow cross-match, The flow cross match is 1 to 3 logs more sensitive than an AHG CDC and can evaluate the T and B cells simultaneously, which in a CDC basic cross match one needs to separate and is less subjective. So the clinical significance of low titer non-complementing fixing antibodies are important when we look at the CDC. The HG-CDC, which was developed in 72, the flow cross match in 1983, this enhanced the ability to detect these non-complementing fixing antibodies. But the flow cross match itself is not without limitations. It does not predict unacceptable clinical outcomes. It can inappropriately deny a transplant, a much needed transplant, because the test is too sensitive. And we also know a CDC cross-match negative, a flow cross-match positive can occur 15% of primary grafts and 34% in retransplants. So that's the kind of discrepancy we encounter when analyzing a CDC cross-match and a flow cross-match simultaneously. But the flow cross-match provides an assessment of risk for graft rejection or graft loss not predicted by a negative CDC cross-match. And in this statement lies the importance of a flow cross-match test. From the evolution of the CDC, we move on to the revolution in transplant. And what was the next big step in revolution? And that was the DNA-based molecular test which came into the typing of the HLA system. Once the molecular typing became DNA-based, the antibodies had to move beyond the CDC cross-match, and then came in the multiplexing for HLA antibody identification. So precise evaluation of HLA antibodies coupled with identification of HLA antigens expressed on donors went hand in hand, and that is the revolution in transplant that we saw. So what are the tools available to us for antibody detection today? So we have the cell-based assays and we have the solid phase assays. And if you look at the development of the tools and the strategies employed, in the 1969, it was the CDC. Then in the 80s came the ELISA tests, the flow PRAs in the 90s. 2000s, we had the Luminex. With the Luminex, we had the DSA lysate, we had the HLA typing on the Luminex platform, and we had the single antigen body testing. And with these, we also now have the C1Q assays, the IgG class 1 to class 4 subclasses, and I'll talk a little later about the significance of each of these IgG subclasses. And now we are at an era where we have the NGS, or the next generation sequencing, and the donor-derived cell-free DNA. So when we look at these platforms, we also need to look at the sensitivity of this platform. And this understanding becomes even more significant when you're trying to compare a cell-based assay and a solid phase assay. We need to understand the sensitivities need to be similar when we are analyzing the result. So the most sensitive would be the Luminex single antigen bead for antibody detection. The next would be the flow, then the ELISA, and the last would be the CDC. So the CDC does require a very high quantum of complements fixing antibodies to be positive. Whereas the Luminex, when you perform the single antigen bead, can pick up very small quantities of antibodies. So a little bit about the techniques here. We have the Luminex. There are various tests available on the Luminex platform for antibody detection. We have the PRA screening, which is when multiple antigens are expressed on the surface of a single bead. Then we have the PRA quantitative, where the beads are expressed on a single bead as per HLA class, for class 1 and class 2. And then we have the single antigen bead assay, where each bead has only one type of antigen on its surface. And this explains this. So the screening bead, which is green, has multiple antigens on it. Therefore, for detecting a particular antibody, the signal will be weak in that case. For the same quantum of antibody on a single antigen on bead assay, where each bead has only one type of antigen, all the antibodies present in circulation will have an antigen to which it can bind and give out fluorescence, and hence a strong signal, which on a screening assay would only give a weak signal. Again, here we have certain issues and problems with the single antigen bead, which I talk about, but prozone phenomena is a term we are all familiar with. I'll refer to it a little later in my talk, but this is the basis of the single antigen bead. And the application of the single antigen bead is the virtual cross match. Not so relevant in our country because I'm glad Nagpur is doing a lot of cadaver transplants. Maybe some amount of virtual cross matching would help there, but most places in India don't perform cadaver transplants, and we're also not flying kidneys from one city to the other or one state to the other. But all the same, the virtual cross match is possible because of the single antigen bead, which is interpreted best in the context of a high resolution HLA typing. Now, in 2006, a study from Duke and Emory University gave the clinical application of the virtual cross match. The UNOS in 2009 mandated a solid phase assay, that is a single antigen bead, to identify HLA antibodies in prospective recipients. The virtual cross match can therefore, as mandated by the UNOS, can predict a positive cross match, a positive predictive value of 90% and a negative predictive value of 50%. Now, this was because antibodies to HLA-C, DQ, and DP were not tested initially. We all are, a lot of us still, but some of us have moved on, but we all do HLA-A, B, and DR, and we think that's enough. But with that, the positive predictive values for a virtual cross match is only 90% and a negative at 50%. And this they figured out was because they were not typing the C, DQ, or the DP locus, following which in 2011, UNOS mandated molecular HLA typing at NGS for HLA A, B, C for class 1 and DR and DQ for class 2. So the benefits and limitations of the solid phase assay as we see the test today. The single antigen bead assay significantly improves the sensitivity and precision of circulating DSA detection. But SAB is not without its limitations. That may impact the interpretation of the antibody strength. So there can be false positive or negative results. And this can be due to antibodies to denatured HLA molecules, which can be present and detected. So that would be a false positive. A false weak negative results could be because of the presence of intrinsic or extrinsic factors that could be inhibiting the single antigen bead assay. A false low MFI on a SAB assay could be because of a prozone, and I showed that in the previous slide. That is because there were too many antigens as compared to the antibodies which were circulating because of the coating of the antigens on the surface of the antibodies. This is caused by the C1 complex formation, culminating in dense C3b or D deposition, preventing secondary antibody from binding to the antibody, and hence the signal is not detected by the Luminex. And of course, biological confounding factors relating to epitope sharing, which can also impact the MFI values. So with that, false positive and negative results of the mainly negative results or positive results on the SAB, we can state very clearly that currently the single antigen bead assay at best provides a semi-quantitative measurement of the antibody strength. So certain actions we take in the lab which help us remove potential inhibitors in the serum by treating the sera with various options that are available, and also address the issue of potential oversaturation of beads in the presence of high titer antibodies. So these are two issues when you would say, oh, the patient has a lot of antibodies, but you're not detecting them on single antigen bead. So those are things we will be discussing. So what are the expectations we have from this solid phase assay? We have expectations in the pre-transplantation period, which would be you want to identify the donor-specific HLA antibodies, quantify the donor-specific HLA antibodies, and predict the cross-match result, whether it's a positive or a negative, which is like a virtual cross-match. In the post-transplant setting, one would want to correlate or predict episodes of antibody-mediated rejection or graft loss, and also correlate with desensitization therapy or rescue therapy in the case of a rejection. So the pre-transplant challenge therefore lies in determining the unacceptable HLA antigen mismatches. Single antigen bead can give a precise determination of unacceptable antigens and also do a virtual cross-match for us. The test helps us in risk assessment in the pre-transplantation period, but more importantly, it also in the pre-transplantation period helps us define the patient's antibody signature. And this is even more relevant in the setting when we are looking for de novo antibodies in the post-transplant period. If we do not have the antibody signature of the patient of the pre-transplant state, it would be difficult to classify any antibodies detected post-transplant as a de novo antibody. And also the relevance in transplanting the highly sensitized patients, the acceptable mismatches, and desensitization. So that is what I've borrowed this slide from a friend of mine from the US, and this is what monitoring for DSA looks like for a patient in the US in the pre-transplant period while waiting for transplant. And so many times, and I'm not able to count even, from 2012 onwards to 2017, the single antigen bead was done till finally a kidney was found for the patient, and then they were able to define whether he ever in those 5 years developed antibodies to the kidney which he was going to receive. So post-transplant care is a challenge, is a greater challenge. And what we are moving on to, and Dr. Pandey brought out very nicely in the introduction, was patients of kidney transplant are on lifelong immunosuppressive therapy. But what we are doing as of today is a one-size-fits-all kind of regime, a protocol. But we want to move towards more specific, individualized therapy for patients in the post-transplant period. And therefore, we have immunological risk assessment, which is the key to individualized immune suppression after transplantation. Now, when we talk about the DSA, the most difficult thing that a lot of us would face, and I'm sure all the nephrologists face, the MFI. So there is an increased risk of ABMR when a threshold of DSA MFI is increased, and this is quoting different studies, anything from 465 to more than 6,000. So there are different centers which have said, for less than 500 to 1,500, 1,500 to 3,000. So that's the kind of issue with there. And the MFI conundrum, therefore, is when you have transplanted a patient with a very high DSA, there is no AMR, and yet with a much lower DSA, there would be a antibody-mediated rejection. So there are many factors which affect the DSA to cause organ rejection. Its antibody affinity, the avidity, the complement fixing ability, the specificity, and of course, the tissue expression of the target donor antigens. So MFI itself does not reflect the antibody concentration. Now, this is a study which was done by Tambour et al. In Chicago, and they published this article in the American Journal of Transplantation in 2015. And they said that the strongest antibody is the one that has the highest MFI at the highest dilution. So it's not just most of us, probably all of us, would just test a neat serum. And if you look at the first, the leftmost part of this graph, the neat serum does not detect the antibodies, but the highest MFI of these antibodies, of the same antibodies, is detected more at 1 in 64 or 1 in 256 dilution. So the stronger the antibody, the higher the MFI there will be at various dilutions. And which is why a lot of centers do look at dilution, at dilutions of serum before doing the single antigen bead and looking at the MFI. So the presence of DSA, we know, is associated with poor graft survival. And there is lots of literature and a lot of studies have been carried out in analysis of retrospective cohort studies of DSA positive by a single solid phase assay with a negative flow cross match demonstrated a statistically significant increase in biopsy-proven AMR and graft failure. So when we look at ABMR in pre-existing DSA versus ABMR in de novo DSA, so the graph on the left side is the pre-existing DSA, is the cumulative incidence of ABMR is much higher as compared to de novo DSA. But when we look at in the post-transplant period, the pre-existing DSA and de novo DSA, the level is again very significantly different. So they compare the ABMR in both the categories, the pre-existing and de novo DSA, and also they looked at the clinical, histological, immunological, and allograft gene expression parameters. So ABMR occurred earlier with pre-existing DSA, but de novo DSA ABMR was associated with greater molecular injury as far as gene expression studies were concerned. They also looked at de novo DSA ABMR had a lower graft survival at 8 years compared to pre-existing DSA ABMR. And this study highlights very, very important feature in monitoring transplant. It's very important to follow up for development of de novo DSA, which brings me back to the point that we need to have a pre-transplant antibody signature of the patient before we can say there is de novo DSA. So the de novo DSA the impact of DSA on organ survival was looked at by Alexander Lupe et al. And they looked at the DSA positive and the DSA negative. Of course, the DSA negative had far better survival as compared to the other groups. And they also assessed the C1QSA along with the DSA. So DSA positive C1Q was even worse survival in the post-transplant period as compared to DSA positive and C1Q negative. So we now have an add-on test to the single antigen bead, which is C1Q, because there is enough literature available that C1Q positive, DSA positive has a worse outcome as compared to those who are C1Q negative. There are other factors which affect the humoral response of antibodies, and those are the amount, number, and HLA class, the binding strength of the antibody to the target epitope, the ability to activate complement, the density, and the protective factors and adaptive capacity of endothelial cells in an individual. So this is how we look at, and the determinants here are the antibody subclasses. The effector functions could be the FC binding, the C1q binding, or the HLA cross-linking. So the recruitment of immune effector cells is what really guides the histological manifestations of antibody-mediated rejection. So if it is the FC receptor binding, which is the most important mechanism of injury, the histological manifestations of antibody-mediated rejection mainly macrophage infiltrate with leukocyte recruitment and macrophage infiltration. With C1q binding, it is the complement activation, and we get more of C4d deposition. And with cross-linking and endothelial activation, there is more of endothelial changes, endothelial swelling, and various endothelial markers which show up. So the end result is the histology we see under the microscope. But what histology we see is guided by what kind of effector function and mechanism of injury that has gone into that ABMR lesion. So the antibody subclass is another thing we look at. There's an antigen, there's a T cell response, of course, through cytokines, differentiation into various antibody subclasses, the IgG subclasses, IgG1, 2, 3, 4 subclasses are the functional differences. And they are functionally different because of their ability to fix complement, their binding to the FC receptors, and IgG1 and G3 are the most effective at complement binding, and hence become the more significant antibodies we would should detect or look for in a assay. So this is another study again from JS in 2016, and they looked at the various IgG subclasses and the histological features. So when they looked at the integrated, the DSA, HLA class, the MFI level, C1q binding, and the IgG subclasses, they find that IgG3 was associated with most lesions of acute ABMR, which is in red, whereas the IgG4 was mainly subclinical ABMR, and the others were all in between. So we're now reaching a stage of contemporary multidimensional assessment of circulating donor-specific anti-HLA antibodies. The level of HLA antibodies cannot be determined by just a plain single antigen bead testing of undiluted sera. And to provide clinically relevant information with respect to prediction of allograft injury and loss, we need to perform serial dilutions and also assessment of circulating anti-HLA DSA, including their ability to bind complement through C1q and the IgG subclassification. So the clinical decision making, therefore, is now at a stage where it's beyond antibody detection. So the two graphs are of pre-transplant and post-transplant, and they combined MFI, C1q, IgG subclasses, all of them or none of them. So the outcome was best. The risk threshold for allograft loss was least when they looked at all these parameters before going in for transplant. The next, when they looked only at MFI, then only at C1q, and then with IgG3. And in the post-transplantation period, again, it was best with all. So in pre-transplant, we can use a mixture of these tests for organ allocation, immune risk stratification, and conditioning to eliminate various harmful antibodies. Post-transplant period, it is the non-invasive tool for clinical decision-making, best for targeted pathogenesis-driven therapies and identification of specific injury phenotypes. A more specific therapeutic approach can hence be applied. So graft survival at 15 years post-transplant. We know the graft survival is highest in patients who never develop antibodies. Those are the lucky ones. Antibodies are present pre-transplant, but not in the post-transplant, is just as good as those who never developed antibodies. But antibodies are present pre and post-transplant, the survival drops to 6%. Antibodies present only in post-transplant drops further to 47%. But look at de novo antibodies, which come up post-transplant. They're the poorest survival. And of course, if individual has developed an antibody-mediated rejection, the graft survival again is very low. So serial antibody screening post-transplant is important. And we need, because we know in renal transplant, the word immunological memory is very important. Even if the antibodies are detected at a very low level, they will come up if the memory cells are present. Pre-transplant DSA, early AMR is 21 to 55%. Persistence of or increase of DSA, we said, is already, it's poor outcome. So HLA antibody testing post-transplant is in effect dictated by the risk profile of the recipient in the pre-transplant period. Then is a question of protocol biopsies and DSA. So please, when I say DSA, I'm actually mean single antigen bead over here. Protocol biopsies are good to detect subclinical AMR, effectiveness of therapy, and identify prognostic indicators of outcome. But in the absence of DSA, detection of subclinical AMR post-transplant on biopsy is low. And de novo DSA, if it's the only abnormality on biopsy you will find, is just microvascular inflammation or subclinical AMR. So these are situations one needs to be wary of and very careful about in the post-transplant monitoring. De novo DSA per se, we know, is associated with a poor graft outcome. We also know that there is, though there is a mean time of about period of about 4.5 years when the de novo DSA comes up, but de novo DSA can come up as late as 15 years post-transplant. There are some factors which predispose an individual to developing de novo DSA, that is non-inherent patients, HLA-DR mismatching, early cell-mediated rejection, young recipient age, and immune suppression switch or withdrawal or non-adherence, whichever it may be. So looking at the time frame of the development of various events in the post-transplant period, the first would be early inflammatory events after transplant, a normal pathology, but the de novo DSA or DSA may be present. Then comes the subclinical injury, where peritubular capillary infiltration, a C4D plus minus, glomerulitis plus minus, if not present, but it's only much later in clinical dysfunction that we get a rising creatinine, proteinuria, and definite features on a biopsy. So post-transplant monitoring actually is guided by the pre-transplant risk assessment. In a very highly sensitized patient, high-risk individual who has been taken up with desensitization, monitor for DSA protocol biopsies in the first 3 months. Clinical, subclinical AMR, just therapy and monitor treatment for efficacy with DSA levels. This is where we stand today, but we have moved on, and I'll come to that at the end of my talk. Rapidly increasing DSA, biopsy negative for ABMR, therapy to reduce DSA. So the aim here would be DSA reduction only. A high risk who is a DSA positive but a cross-match negative who has been taken up for transplant, a biopsy positive or a rapidly increasing DSA with negative biopsy, you would still do therapy and monitor DSA. A DSA, if it persists, but the biopsy is negative, additional monitoring and continued immune suppression. A DSA negative and a biopsy negative, followed up as a low-risk patient. The intermediate risk is not a problem, and the low risk is a non-sensitized patient who is taken up for transplant, and you only need to monitor him when you're either changing the immune suppression or if he's going to a remote area and cannot be monitored for a long time. So with this little background on what we have today, what we can do, we have a new test on the block, and I'm happy to say that we validated and launched this test recently, and that's the donor-derived cell-free DNA. The concept here is simple. There is a kidney transplant where you've introduced a foreign antibody into another recipient, and the test detects the level of cell-free DNA in the circulation of the recipient post-transplant. So the most important thing here is that it is a non-invasive test. It's a very sensitive test, and it can differentiate active rejection where the percentage of cell-free DNA goes up as compared to a no active rejection where the levels of donor-derived cell-free DNA do not go up. So current transplant surveillance, we've talked a lot about this, but we have the creatinine, and I've already shown that creatinine comes up far too late when the injury has gone beyond a certain stage to the transplanted organ. DSA itself, the single antigen bead, has a poor positive predictive value for ABMR, and the biopsy is not expensive in our country, but it's inconvenient, it's potentially morbid, and there are interpretation challenges. We know nephropathologists can differ widely and to a huge percentage in their opinion about the biopsies. And I don't mean to say anything about them. I'm myself a pathologist, so there's no hard feelings out there. But those are issues with biopsies, and particularly small biopsies. So when you're monitoring with the donor-derived cell-free DNA, it's a beautiful monitoring test where you would monitor in the post-transplant period, start at 1 month, at the 2nd month. If you detect an increasing level of cell-free DNA, that would be the time to go in for the biopsy. As of today, we still consider the renal biopsy as the gold standard, but we don't need to monitor with a biopsy. The test is going to help us decide at what time point to do a biopsy. If I was to go and do a biopsy at stage 1 in this graph, it would be a negative biopsy. It would have no outcome as far as information is concerned. A biopsy at step 2 may not pick up the features or findings of an antibody-mediated rejection, but a rising level is the time at point 3 where an individual should be biopsied, results correlated, and then therapy started. Again, to monitor the effectiveness of therapy, one could just do the cell-free DNA at stage 4 till the levels of the cell-free DNA come back to level 1. So looking at a little bit about the donor-derived cell-free DNA, and a lot of people tend to call it the liquid biopsy of a solid organ transplant, it helps discriminate active rejection from non-active, no active rejection with a very high accuracy. Definitely, it is far more accurate than serum creatinine, and a lot of studies have looked at serum creatinine and cell-free DNA, because creatinine is what we have available to us easily, is highly sensitive in distinguishing ABMR from no ABMR, and if levels decrease following successful rejection, it is definitely the test for monitoring therapy to rejection. So these are a few studies which are carried out using AlloSure, and AlloSure is the commercial name. Also AlloSeq, which is how it is known in India, is a test which is the donor-derived cell-free DNA, is highly sensitive in distinguishing ABMR from no ABMR. So if you look at the first graph, there is no ABMR and the levels are all below 1%. whereas in ABMR, it is much above 1%. And 1% is the normal cutoff for donor-derived cell-free DNA. And a very sensitive p-value is less than 0.001. And if we compare it, look at serum creatinine, and the creatinine is hardly able to differentiate no ABMR from ABMR, where values in both the non-ABMR conditions as well as the ABMR conditions are all in the range of about 2 milligrams per DL. So it is sensitive, and there's the study by Stanley Jordan et al., which was published in Transplant Direct 2018, and they said that the donor-derived cell-free DNA had an 89% positive predictive value for detecting ABMR active when the cell-free DNA levels was more than 2.9% in DSA positive patients. And it was 81% positive predictive value when the cutoff for cell-free DNA was 1% for active ABMR. And the negative predictive value was 83%. But the positive predictive value of just a single antigen bead alone is only at 48%, which is the test we are using and the best test available to us. The patients with donor-derived cell-free DNA positive, DSA positive have the highest probability of active antibody-mediated rejection. So they, in their study, recommended a combined use of donor-derived cell-free DNA and DSA testing to improve the non-invasive diagnosis of active ABMR in kidney transplant patients. And that was another study by Brennan et al., again in American Journal of Transplantation. And they, in their study, concluded that donor-derived cell-free DNA may be useful to detect and subsequently assess recovery. And their focus was mainly on the monitoring of therapy post-rejection. What would be the time schedule for testing? These are American recommendations, and I know we cannot afford to do these this kind of a schedule in India for most patients. But yes, the recommendations are to do the test once a month for the first 4 months, every 3 months after that, and then once a year. So this is what is recommended, but the aim is to follow up the patient and monitor the patient depending on the pre-transplant sensitization and the post-transplant performance of the kidney or the graft. So the test can be added to the previous protocols. We are monitoring for creatinine, we monitor for BK virus, we monitor for DSA. We don't monitor for all, but yes, we do monitor for the sensitized patients, and the test can be added to the table of monitoring post-transplant for patients. So the goal of accurate risk stratification for allograft injury and failure, of course, always for all of us remains improved clinical transplant outcomes, tailored therapeutic strategies in pre and post-transplant period for desensitization and monitoring post-transplant. We know most of these therapies do have side effects and other complications, and also incorporate predictive risk for adverse outcomes to minimize benefits and also maximize benefits and minimize harms. So with that, I end my talk. I have just shown that long road. I know we have come a long way, but probably we still have a long way to go as far as improving the transplant outcomes for the patients. And I will be happy to take questions after this. Yes, thank you.
Thank you very much. It has been a very thought-provoking talk, and there are so many questions that has come into my mind during this talk. And it appears that there must be many questions amongst our colleagues who are involved with the transplants. So you may shoot your questions to Madam. She is ready to answer.
Madam, I would like to ask one question. Like, can you hear me?
Yes, I can. Yes, please.
Uh, in Nagpur, we do cadaver transplants. Now, there are some nephrologists willing to wait till the report of Luminex comes, but because they're willing to risk the cold ischemia time, a little longer cold ischemia time. But there are others who would want a CDC report very early and not willing to wait for a cadaver transplant. So what is your opinion on that? What should we be doing?
So definitely a CDC cross match is indicated in a cadaver transplant. I can tell you what we practice, and a lot of other people also practice who are situated a long distance from a lab which can do certain amount of testing. So what they normally do, and we know that in the immediate post cadaver transplant period, the immunosuppression is high. So they would go ahead with the CDC cross match and do the transplant. Take a sample before the transplant for single antigen bead. This is before they've done the put the graft, and then also send an HLA-NGS. And we have the turnaround time of 1 day for the single antigen bead for these cases, and the NGS within 4 days. So by the time they begin to taper the immune suppression, these results are available, and they have a pre-transplant DSA. There are, of course, some centers which are performing single antigen bead for patients waiting for a cadaver transplant, but we don't really know when a cadaver transplant is going to happen. So the best is to take a serum sample for single antigen bead and send it for testing immediately, and link it to an NGS. You have the result ready within 3 days, 4 days. You have both the results ready, and you are able to then know if your patient had a high DSA, be prepared for plasmapheresis, or howsoever you want to take the transplant forward. But yes, cross-match is mandatory and is done, and there is no point, in my opinion, waiting for a Luminex report for a cadaver transplant and prolonging the ischemia time.
So you would suggest that we should have a CDC report in hand before they go for a transplant, but DSA report can wait for post-transplant time?
So yes, the DSA...
We can have a DSA after.
So a DSA report sample should be collected in the pre-transplant, because that is most precious. We don't know about DSA, de novo DSA. We don't know a lot of antibody signatures if we don't have that sample. So that sample should be collected and sent immediately to a lab which is going to test it, and then also link it to a NGS, which is a high resolution HLA typing, and the single antigen bead is best interpreted in the context of a high resolution NGS HLA typing. So that was the recommendation.
And one more question, madam. Post-transplant, you said that monitoring of DSA level should be done. But if it is a cadaveric post-transplant, are we supposed to save the hemolysate of the donor to do a DSA, or we just do a single antigen bead assay?
So a DSA lysate is I don't like saying this, but it's a poor man's single antigen bead. And it does not give you enough information. When the world is moving at dilutions of single antigen bead and C1q with single antigen bead and IgG subclasses, and we don't want to go back and start looking at DSA lysate. The test there would be a single antigen bead to monitor a donor-derived cell-free DNA to monitor. These are fantastic tests to monitor. Of course, the recommendations and a lot of articles is to and minimize to a huge extent the need to do a invasive biopsy, but those are the tests which are recommended to monitor the patient.
I don't know how many would be able to afford single antigen bead assay on a regular intervals in Nagpur.
So,
that is a bit.
so I just want to bring this point, Dr. Mundra, is that the DSA lysit is not going to give you enough information. All it will tell you is MFI trans 2 is 5,000. It means really nothing. Is that 5,000 to one antigen? Is it distributed across all the class 2 HLA or all of class 1 HLA? We really don't know. It doesn't, a DSA lysate at class 2 or class 1, whichever, pre-transplant MFI 1,000, and post-transplant the same DSA lysate at 2,000. I don't see any difference. And I don't see any fruitful information being communicated to the clinician for this. I would think it was a waste. You might as well just do it blindly. The DSA lysate is a test which is not being performed in the world. I know single antigen bead is expensive, but you need to monitor to prevent the patient from going through. Why do you want to keep increasing his immune suppression when we know that's not without side effects? He doesn't have antibodies, you want to change, you want to, there is so much you can do if you have accurate input of lab information to help you monitor the patient. So that is how I would look at it, and that's how probably we could do a lot of tests. Again, the cell-free DNA would give you levels where the injury to the graft is happening, and that can help you know that there is some injury which is starting. DSA is present. DSA may or may not be very high, but it's getting injured. DSA will eventually go up. You're prepared for the eventuality. You're going to prevent a situation where the patient has developed an AMR, and then you're not going to have such a good graft survival. Dr. Acharya spoke about his patient who was 17 years post-transplant, doing very well. He was probably lucky. He didn't develop anything. He was probably not sensitized. He had antigens which donor had antigens with which he was compatible. I don't really know the matching status of that patient, but we have all kinds of combinations in kidney transplant.
Mother to son, one haplotype match.
Yeah, okay. So he would still have antibodies, but probably there were antigens which didn't have were not very antigenic in the sense they did not produce many antibodies to them.
From this discussion, it appears that the flow cytometry cross-match does not have any role as on today.
So I will not, Dr. Acharya, agree with that. The flow cytometer flow cross-match has one big disadvantage. It's too sensitive. You don't want to stop a transplant, which is CDC cross-match negative, done in a good lab, presuming all results are correct. A CDC cross-match negative, flow cross-match weak positive, please go ahead with the transplant. The problem we face is that the flow cross-match is a very sensitive technique, and we tend to compare it with either a CDC cross-match or a test which is not so sensitive. You need to compare two tests which are at the same platform. A flow cross-match, if weak positive, the test you do for antibody detection is the single antigen bead. Then you're able to say, okay, flow cross-match very positive, but the MFI to this particular DSA is only 1300. You can go ahead with the transplant if the CDC is negative also. The CDC, because such a time-tested, very sensitive, and the actual only contraindication to kidney transplant. So you never go ahead with a positive CTC. That's because a CTC requires a huge quantum of antibodies to be positive. So flow cross-match has to be seen along with single antigen to make a clinical decision. So those are issues I encounter them often enough in my daily practice. Oh, this came positive, this came negative, this is weak positive. How do we? So we're doing this all the time, and learning all the time from these.
Madam, I have a scenario for you. I have a sensitized patient, and she is sensitized towards her brother, and we have a DSA profile of her single antigen read, and now obviously the brother is out, and I don't want to desensitize and proceed. So now I'm trying to enter into a swap position, swap transplant. So here, this I have the advantage of someone uh, reporting this particular single antigen bead uh, profile, and someone looking out for all the epitope sharings and then telling me that these MFIs are important towards this particular antigen. But when I enter into a exchange kind of scenario, the HLA typing is probably of a different resolution, or probably from a different lab. And more importantly, I have no clue about the epitope sharing, the CREGs as they call it. And I don't know how, I cannot just look at the face value of that particular HLA typing report and say that, okay, these values are not here. So what I'm talking is, how do I know whether there is an unacceptable match or whether there is an acceptable?
Yeah, so I get your point. I cannot comment on the lab, but like I said, a single antigen bead must be seen in conjunction with an HLA typing at high resolution or NGS, because the single antigen bead gives you the antigen and the first two. That is, it's a 4-digit report, right? Single antigen, like 2401. So, right? Whereas the HLA NGS will give you at least 6-digit, if not 8. So that's okay. It's more than what is required. But you only look at the first two. You can ignore the third and the fourth field if it's there with the report. So how we do the single antigen bead in our lab, and how I discuss it out with the clinicians, is that if we've done single antigen bead and the NGS, now NGS takes 4 days to turnaround time, and single antigen bead we are able to, in situations where they require, give the report the same day. So we will take out one report which will enumerate all the MFIs. Once we have the NGS report, we always make a supplementary report to that report after analyzing it in conjunction with the NGS. It's only then you can comment on the DSA. With a low resolution Luminex report of the HLA, you can never say you have HLA A24. You can have antibodies on single antigen bead against 2401, 2403, 2404, 2410. Now, all of those, if somebody gives me a low resolution report to analyze the single antigen bead, I will put all the 24s as probable DSA present. I cannot say. Now, that was one part of the question. The second part of the question is the epitopes. So the analysis of the epitope, I do a discussion with those who want to discuss the epitope analysis with me. We are not reporting epitopes as yet because it's not yet in clinical use as such. But yes, we can look at the epitopes and say these antigens share epitope. If the donor has 2 or 3 antigens which share the epitope with, sorry, if there are 2 or 3 antigens which share epitope with an antigen epitope in the donor, it means the antibodies are going to compound. So there are antibodies against this, but they will also act against that. So if you were there at the beginning of my presentation, so if B7 is there, but they would have antibodies to all the CREGs of at different concentration. But if there's antibodies to B7 and the donor happens to have B27, there will be some antibodies to B27 by virtue of antibodies to B7 being present. So that analysis has to be done, carefully look at the donor HLA typing, look at the epitopes, sharing between the various antigens, and then go ahead. But a lot of epitope analysis really not being used in clinical practice so much to take a decision on to go ahead with the transplant or not. But yes, DSA per se, definitely. If you look at the epitopes, when you're analyzing, one can make out, okay, this will cause an issue subsequently, which can be communicated to the clinician. Yes, definitely.
If we are in a, thanks for that elaboration. So if we are in a exchange scenario, then can we avail, for example, your expertise or services for getting a reported virtual cross match, so to say?
Yeah, so definitely we can work on it. You can discuss it. My number's there with Dr. Pandey. Anybody in your city can definitely. I'm doing it all the time, so it's okay. I don't have any problems with that. Yes.
Okay, that's good to know. Thank you.
Good evening, madam.
Good evening.
Are we doing this subtyping of the IgG antibodies or the C1q DSAs in our country?
Yes. So we in our lab are doing C1q with SAB. Yes. So how it's done is you do the single antigen bead test, and we know the antibodies that we detect, and then you do the single antigen bead with an additional C1q assay incorporated in that, and antibodies which are antigen which are C1q binding will get detected, and those which are not will not get detected. So that's how we differentiate and say, okay, these are DSA, and this much DSA is complement fixing, and this is not complement fixing. So that's how the test is analyzed, and we are doing the test. Yes.
And the subclasses of the IgG?
Yes, so we do the subclasses, we validated it. There are not many people who want to do it because of the same reason, there's so much to do. So, yeah. But yes, if there is a rejection, you want to further analyze the DSA that you have detected, whether what type of antibody. So if some case has to be worked up in detail, yes, we can do the IgG subclasses.
Okay, thank you.
Can different labs have different reporting of the HLA?
Sorry, I'm sorry, I missed you there.
If we send the same sample to different labs, if we send the same sample to different labs, will the reports come differently, or is it standardized all over the world?
So are you talking about the single antigen bead?
Yeah, single antigen bead.
Okay, no, you will not. And this is a big issue, and there is enough literature that has been published. There is different vendors who give the test. What I would recommend is, if you are sending to one lab, please send to the same lab for the monitoring, because the two main vendors who are there in India, they have different bead sets, different beads which are in the single antigen bead, and the MFIs detected for the same antigen are different in between the thing. So if you're monitoring, please monitor with the same vendor. If you want, I can, there are articles on this where vendor issues, they've discussed this at length in various conferences. So if you use one lab for monitoring, instead of lab hopping, it's better to follow the same and not say, oh, this one was 2000, this is 1500, or the beads were different. So that's important in thing. But I think most people who do transplants send the same test to the same lab for monitoring a particular patient.
Why don't we do a cross match for the liver and heart transplants?
So for the heart transplant,
is there in both the cases. Blood vessels are there in the heart and the liver also.
So the cross match is very much indicated in the heart transplant, but we have to understand the kidney is a human source, but it's more easily available than the heart. To be a donor for the heart, somebody has to die. But yes, cross-match is important. PRA is very important in heart transplant. Donor-derived cell-free DNA is absolutely essential in heart transplant. The biopsy there is very morbid, can be high mortality and everything. There's lungs to go through, there's a thorax to go through, there's a lot of punches that can happen. So endomyocardial biopsy is a problematic biopsy, no doubt. But yes, PRA, single antigen bead, donor-derived cell-free DNA are very relevant in heart transplant. The liver transplant, it's not an issue. Liver transplant is an immunological haven. They do not react. The expression of antigens is not so much, and hence they do not have the issues of antibody-mediated rejection like in the other solid organ transplants. The issue they have is more like a bone marrow transplant, which is the graft versus host disease. So that's a different kind of liver dysfunction that would come up in the post-transplant period. So the heart definitely should do a PRA, at least a single antigen bead and a cross match.
Ma'am, when we have a waiting list prepared for a transplant recipients for cadaver, do you think PRA level should be done in all the cases then?
So the graph I showed you from US was how they monitor, that was for a patient from 2012 to 2017 waiting for kidney transplant for 5 years. And that was all done on single antigen bead. I know we cannot do it, so we will just look at such a graph and appreciate it, and that's about all. But we should not only do a PRA, yes, we can do a PRA and monitor them over a period of time with PRA, but the test which must be done pre-transplant is the single antigen bead. So a lot of states, particularly Tamil Nadu, Karnataka, who are very high on cadaver transplant, do PRA and keep a waiting list based on PRA, because allocation also depends on the sensitization of the patient. The patient who's getting faster sensitization needs to be given a graft faster. That's one of the principles of allocation. So how else can you make out whether he's increasing sensitization or he's not changing his sensitization state is only at least with a PRA, if not a single antigen bead.
You mean to say a person with a high PRA level should be at the top of the list as compared to a person with...
Yes. So that's how allocation occurs, because the more faster he's getting sensitized, the faster he's getting...
Cross match would come negative. The cross match would
yes,
come...
Yes, if he's highly sensitized, he need not... So you want to take him up for transplant before his cross match becomes positive to all the donors. So you want to take him up and he moves up in the ladder faster. So that's one of the principles of allocation of kidney transplant.
So can we take this message that 12 antigen match should be done along with DSA in each and every kidney transplant prospective recipient, irrespective of sensitization status?
Yes, that would be the most wonderful situation. But if you have definitely for any patient who gives you any history of sensitization, multiparous, transfusion, of course a second transplant, etc., definitely a single antigen bead and a high resolution HLA typing A class 1, class 2. Nice to do a DP also, but ABC, DR, and DQ definitely, because we know DQ antibodies are deleterious in transplant. Yes, if you have a very clean patient who's not been on dialysis, not much infection, cannot afford, at least a good quantified PRA can help. But if he can, the single antigen bead is the test you should. You don't know what's going to happen to him in the post-transplant period. And it's very sad sometimes. You don't have the serum and you don't know what antibodies were there and what is it you are detecting. And if the patient really can't afford, then the least you can do for the patient is save his serum should you need it 1, 2, 3, 10 years down the line. I mean, that's the least you can do for the patient. I have done at least 5 cases where they have sent me the pre-transplant serum along with the post-transplant. Yes, those pre-transplant serums were only 1 month. These patients were those who had rejection within a month or 2 months. So the pre-transplant serum was available with the hospital or whatever. So it helps. It helps in understanding the post-transplant immune profile of the patient. Otherwise, you don't get the full information from that test.
And what are the confounders for this cell-free DNA?
Sorry?
What are confounders for donor-derived cell-free DNA? Only
So
in
there are
cellular rejection. What are the confounders for donor-derived cell-free DNA?
Okay, for donor-derived cell-free DNA, it is the best test to monitor antibody-mediated rejection, differentiate from non-antibody. It will pick up any active antibody-mediated rejection, be it acute active or chronic active antibody-mediated rejection. Now, there was the T-cell mediated rejections. When you look at it, you are going to look at the donor-derived cell-free DNA, which will be able to differentiate a T-cell 1B or above, 2A, 2B, 1B. Now, there is recent literature also, which I didn't show because the focus was more on this. There is recent literature that it also does help differentiate T-cell mediated rejection 1A. So it gives you a full range of antibody mediated and T-cell mediated rejection. Now, what is it that can limit the cell-free DNA interpretation? That it will not help differentiate probably. There is a lot of literature on this, a BK virus related infection, where you want to discriminate. If it's an outright antibody mediated and BK virus, no problem. But if it's only BK virus, some little graft dysfunction, you need to then look at the entire gamut of tests put together. It's not an absolute answer that you will get over there. So that will limit the donor-derived cell-free DNA. But the levels of cell-free DNA that will be detected in antibody and a T-cell mediated, the levels in antibody mediated rejection very high. The levels in T-cell mediated are high, that means above the cutoff, but not as high as they would be in ABMR, which is why in that slide I said 2.9% and 1%, the positive predictive value varied from 89% to 83% 89% when the cutoff, when the values were in the range of 2.9%, and it was 83% when the values were just above 1%, which is the cutoff over there. So those are features which will limit which will help you differentiate and put the test in the perspective of what is actually happening to the kidney. So I hope that answers, or is there anything else you want me to?
Over a period of time, this donor-derived cell-free DNA test, we may avoid doing protocol biopsies in such a situation.
Definitely. So that's the intention. Again, I said I'm a pathologist first. So I'm not undermining the importance of the histopathology or a biopsy at any point of time. But yes, it's going to a huge extent, help you decide at what time point to do the biopsy. You actually would do a protocol cell-free DNA and then say, okay, now is the time I will do a biopsy and I will get a confirmatory result on the biopsy. Only if the levels, if you're monitoring and you're getting good levels of less than 1%, 0.04, 0.5, and it's going like that, it's not antibody mediated rejection. It could be any of the other injuries which could cause, or creatinine could be going up, but not because of rejection. There could be so many other causes there.
So every time
Yes,
when we order a donor-derived cell-free DNA, we need to send a HLA report of donor. How do we identify?
We don't know. So that's the good thing about the test. It's done on the on a unique platform called the NGS, Next Generation Sequencing. The identification has nothing to do with the HLA. The test is validated internationally. It's a test developed in the US, where they look at the SNPs, the single nucleotide polymorphisms, and they look at a set of 202 single nucleotide polymorphisms, and the company has come up with these 202 SNPs, which help differentiate donors and recipient after typing. I don't remember the exact number, but there's over million of population and all kinds of ethnic groups. So it's again like those questions. A PRA is ethnic. Does it have the antigens for Indians? So all those issues do not. It's across the genome. It's across all ethnic groups, and they look at SNPs, and the software is able to differentiate the donor from the recipient. So most levels, the test detection cutoff for kidney, it's different for different organs. It's higher for lung. It's lower for heart because it's even more sensitive for that. And for kidney, the cutoff is 1. Between 0.5 and 1 is a orange zone. It hasn't gone to red, but if it's going above 0.5% of donor-derived cell-free DNA, it's you need to start watching out. At 1% or above 1%, it's definite rejection. But it's and the software very nicely differentiates the SNPs which are there between the recipient. Actually, it's so well done that you don't even need to do the typing of the patient or the donor, do the cell-free DNA of the patient or the donor before the transplant. You don't need the donor sample at all. All you need is plasma of the recipient, and there's a very special tube called the Streck tube, in which the sample has to be collected, transported within 24 hours to 48 hours in a Streck tube at room temperature. So, and then we extract the plasma from that and the cell-free DNA from that. I don't know if you're familiar with this chimerism testing in bone marrow transplant. So this is like that test for the solid organ transplant now. Yes, but it's the opposite in bone marrow.
What is the cost of that test? What is
Sorry?
the cost? What is the cost of that test?
We launched it already.
No, cost.
The cost, I will get the salespeople to come and speak with you. So they will, we have a special launch prize for this. And like I said, the first lab and the only lab in the country doing this test. And I thought it was important to bring this test for our patients. And my next target is going to be the gene profiling in kidney transplant. On the peripheral blood, so that we can do away with the kidney biopsies and the inconvenience to the patient.
Yeah, if we combine this test along with the test against, say, CMV, against all this, so without actually doing a biopsy, we may come to a conclusion that what is the kind of histology which is likely to be.
So, yes, so virology workup, DSA, and donor-derived, and you have the entire answer. You don't need to do a biopsy. Again, I say a lot of biopsies which are borderline, which are not clear-cut in the, when the diagnosis cannot be so easily made. There's a lot of variability in the opinion of various pathologists there also. So it's that's how it stands today. Yes.
Is there any other question from any of the attendees?
So I just make a few points about the cell-free DNA. Because it picks up injury, the test is not to be done 14 days after transplant, because that's when the kidney has undergone injury already. So you should not do it immediately after transplant. That's why we recommend the first at 1 month after transplant, or definitely not before 14 days after transplant. It cannot be done if the patient has also had a bone marrow transplant. If he's had a bone marrow transplant, then has a kidney transplant. Cannot be done in monozygotic twins. But I don't think they would look at rejection. They would be very happy otherwise also. And cannot be done if they have received in the last 30 days blood transfusion, which is not leukodepleted. If it's leukodepleted, it's okay. But if it's not leukodepleted, we would expect some amount of cell-free DNA there. And of course, it can be done in retransplant. That's not a problem of kidney. But if multiple organs have been transplanted in the same, like a liver kidney or a pancreas kidney, again, the test, because they would be different donors, the test is not then recommended. Because even if it's the same donor, where is the injury happening? Is it in the pancreas? Is it in the kidney? So that would make analysis difficult. So these are conditions where the test is not recommended, and otherwise I think it's good for monitoring. And I just got a registration from for a cell-free DNA, where the doctor in the clinical note wrote the patient is refusing a kidney biopsy because he's a second transplant, and he doesn't want a biopsy. So hence we are offering this test. So which probably is something you see in clinical use. They don't want a biopsy. People are scared of the needle sometimes. So it's a good option there.
Madam, since you mentioned leukodepleted PRCs, sometimes we do not get leukodepleted PRCs, and so in that scenario, sometimes if we use a leukocyte filter, is that good enough? Is that effective enough?
I'm sorry, I lost the Zoom over there. Can you hear me?
Yes, we can.
Oh, okay. So I'm okay with that. So your question was, can you?
Since you mentioned leukodepleted PRCs being so, if we sometimes do not get leukodepleted PRCs, do you think the WBC filters that we externally use would be good enough?
Yes, yes, you could use those, but I would recommend you mention that in the clinical notes so that the lab which is testing is aware that there has been leukodepletion, but probably not may not have be sufficed. So that would have to be seen and the result analyzed according to that. But it would definitely be something worth noting and informing the lab in the clinical notes, surely.
Thank you.
Is there any further question? If there is none, then Madam, I must say that this talk has been one of the most memorable talk that I have heard since many years. And thank you very much for that. It's excellent in-depth talk about this very complicated subject, and it's going to help us in management, day-to-day management of transplant patients before and after transplant. Thank you very much. And now I hand it over to Dr. Vishal Ramteke for the vote of thanks. Thank you very much.
I think Vishal has left for some important work. And thank you, madam, on behalf of the Nephrology Society, accept our heartfelt thanks for such a wonderful, thought-provoking lecture. Thank you.
Thank you so much. I've enjoyed interacting, and I'm absolutely open to any queries you have, any specific questions. There is just no problem. We can talk. My number is there with you. You can share it with other doctors if you like. It's not a problem. And very nice to interact. And I hope your cadaver transplant does go places, and you do well in that, surely. So thank you so much, Dr. Pandey, and the Nagpur and Vidarbha Nephrology Society. Thank you.
Thank you very much, and take care of your health, my dear friends, and be careful. In recent future, we are hearing a lot about the third wave. Please take care of yourself. Shubham, all the best. Bye-bye.